said, endocrine hypertension is a very topical thing in clinical practice. I hope my slides are visible now. So here we start again. Endocrine hypertension, 34-year-old lady, presents with history of hypertension, detected about a year ago. Systolic blood pressure 150 to 80, diastolic 94 to 100. Started on amlodipine 5 milligrams once daily. Very vague history of headaches, very vague history of palpitations. Gained 6 kg in weight after marriage and after having a first child. No significant past medical history. Menstrual history is normal. Normotensive during pregnancy. Important information. Mother has diabetes. Father has hypertension. Sister is on thyroid hormone replacement. Non-smoker. Occasional alcohol. IT professional. Pulse is 88. Not tachycardic. Blood pressure is high. Small firm goiter. She's on the obese side. BMI is 29. So the question comes. Certainly, we need to take a more detailed history and do a thorough examination, need a few basic laboratory test values. I'll come to that later. The question to you is, should we consider endocrine causes of hypertension in this lady, or is it just essential hypertension after all? How many secondary causes of hypertension cross your mind that you think that you need to exclude in this 34-year-old lady? And how far should one investigate to exclude secondary causes of hypertension in this 32-year-old lady? I'll just go back to the slide. I'll give you about 10 seconds for you to list the number of causes that are crossing through your mind as to number one, whether will you at all look for secondary or endocrine causes of hypertension? That's first question. As Koller does not show yes, no. If it is no, then it's over. If it is yes, then can you list the number of causes? I'm not saying there's one diagnosis here. There can never be one diagnosis when a patient walks into your clinic. Hypocalcemia, only one diagnosis. But endocrine causes of hypertension, there are so many causes. So any of them might fit into this young lady, or maybe none fit into this young lady. It might just be essential hypertension. So 10 seconds. Okay, with that I'll go on. So magnitude of the problem. There are no prospective multicenter studies in young age group to tell you what percentage of people have endocrine or secondary causes of hypertension. Many series, observational data, etc., etc. Majority of the people still have essential hypertension. The percentage of people having secondary hypertension, endocrine causes of hypertension can range from as low as 5% to as much as 15%, depending on which series you are seeing, which observational data is seeing. Is it coming from general practice, or is it coming from institutional practice? Is it coming from an institution which just specializes in endocrine hypertension, where obviously the prevalence will be much higher? So we divide the causes of endocrine hypertension. There are many ways of defining it. You take the endocrine reviews, this got a nice table. Take Williams' textbook, got a nice table. This is how I work. I divide them into adrenal causes and non-adrenal causes. Now, angiotensin 2 mediated or angiotensin 3 non-mediated doesn't make too much of a difference. But when the first time patient walks into my clinic, less than 40 years of old age, renal artery stenosis calls into my mind. It's underlined here because she's a 32-year-old woman who's got blood pressure. You should think about that. Renin producing tumors I have not seen in my 35 years of career so far. The discussion I would like to hear if anybody has seen one. Generally, they are large at presentation, 4-5 centimeters. This is theoretical knowledge. Coarctation of aorta. I have stopped doing differential pulses now. As a student, I used to do nicely radiofemoral delay, but that doesn't mean, do not say that in the examination. Please say that, because coarctation of aorta is a clinical diagnosis, should not pick up. It should pick up. Oral contraceptive pills should cross your mind in this 32-year-old lady. Should ask for that. Acromegaly, she's not. Hyperparathyroidism, hyperthyroidism, hypothyroidism, diabetes, and obesity all cause hypertension. Mechanisms are very odd. In diabetes, anywhere between 40 to 60% of people have associated hypertension. Common soil hypothesis, it is said. Obesity is a very common cause for hypertension, and OSA is a very common cause for hypertension, but I will not be delving into these because these are straightforward, simple. Acromegaly comes to you, you think about acromegaly rather than hypertension. Hyperpara does not come to you with hypertension. It comes with hypercalcemia, and then you pick up, oh, there's also some little bit of systolic diastolic hypertension. Hyperthyroid comes with shaking hands and a goiter and prominent eyes. It doesn't come with systolic hypertension to you in the clinics. That's not how you suspect hyperthyroidism. Same for hypothyroidism. They generally have some diastolic hypertension because of increased sympathetic tone, and there are lots of research work done on that, but that does not make much difference in management of hypothyroidism. We manage with thyroxine hormone, which can be glucocorticoid, could be glucocorticoid hypertension, which could be medullary causes of hypertension, or which could be mineralocorticoid hypertension. Of these, Cushing syndrome is a sitter. You can pick them up clinically, and I'll come to you with some patients who have got the subtle signs and symptoms where you should be thinking of Cushing's, very easy to exclude. Pheochromocytoma and mineralocorticoid hypertension generally will not come to you with any clinical clues. So this is where you have to use your laboratory. Coming back to this slide, renal artery stenosis also doesn't come with very many obvious signs. You have to think about it. You have to investigate for it. Others are sitters. So these are secondary causes. And one thing which I've not mentioned, because it's endocrine causes of hypertension, the commonest cause of secondary hypertension is renal disease, raised creatinine causing hypertension. So that you'll obviously get when you do a basic laboratory test. Now coming to this slide, Cushing's and pheochromocytoma, I'll come to in more detail. Now when you think about mineralocorticoid hypertension, means there's hypertension, hypokalemia. You have to divide it into two different ways. One is aldosterone is high, renin is suppressed. The other is aldosterone is suppressed, renin is suppressed. Both are mineralocorticoid hypertension. In both cases, there's hypertension and there is hypokalemia. On the left side, the hypokalemia is because of elevated aldosterone. On the right side, it is aldo is suppressed, but still there is hypokalemia because there are drugs, molecules which are working like a mineralocorticoid and causing potassium loss, kaliuresis. Now, CAH with 17 alpha and 11 beta hydroxylase deficiency, I can count on my fingers that I have seen. They are very, very rare. So you can forget about these two causes. They are in a very specialist centers. Even specialist centers, they sweat to diagnose 17 alpha, 11 beta, unless and until they have all the genetic markers. Now, the third one, you should be careful. You should be careful about, especially in India. You heard about the talk where Dr. Keno was talking about cortisol to cortisol conversion, cortisol to cortisone conversion. We have an enzyme called 11 beta hydroxydehydrogenase, which he was telling, which inactivates cortisol to cortisol. Now, cortisol in the kidney can act exactly like aldosterone. It has mineralocorticoid properties. What saves you and me, all of us, is this enzyme called 11 hydroxydehydrogenase, which inactivates the cortisol to cortisol in the renal level. So they do not cause the mineralocorticoid hypertension. Now, if you have congenital deficiency, it's called apparent mineralocorticoid excess, which you and I will not see. This is more of a pediatric issue, will be seen by our pediatric endocrinology colleagues. But we may see something called a licorice-induced or carbonylaloxone is no longer used. This was used for peptic ulcer disease. Cushing syndrome again presents with Cushing syndrome, so don't worry, the hypokalemia there is because of excess cortisol acting like a mineralocorticoid. But what you need to worry about is licorice. Licorice is a root which gives sweet taste. So many chocolates, gums, etc. have licorice. I don't know our Ayurvedic medicines, how many of them have this jadi booty in it. I do not know. So if I see somebody with hypertension, hypokalemia, I'm very sure this is primary hyperaldosteronism, but my aldosterone done twice or thrice is below normal, then this is what you should consider of. Little syndrome is very rare. I can count on my fingers that I have seen. This is a genetic defect at the renal tubule level, where there's increased sodium retention, hypertension, and hypokalemia. DOX secreting tumor or glucocorticoid receptor resistance, these are all good to know for various exams to tick the boxes. But in a real life, what you will probably come across is licorice, or if somebody is still using carbonylaloxone, and the very background is Little syndrome. But majority of the time, mineralocorticoid hypertension will be primary hyperaldosteronism, where there will be increased aldosterone, decreased renin, and these are the various causes of primary aldosteronism. I think we do not need to go that for a general audience. So, when should secondary hypertension cross your mind? We have discussed. We'll come to it in the conclusion slide. Classification I've taken you through: barn door obvious non-adrenal causes and adrenal causes, which can be Cushing's, pheochromocytoma, or the mineralocorticoid hypertension. Commonest among them is the mineralocorticoid hypertension. Take a 31-year-old gentleman, amlodipine atenolol, developed episode of lower limb weakness, barn door hypokalemia, blood pressure 180, 120 on a beta blocker and on a calcium channel blocker, potassium low, creatinine normal, creatinine clearance okay. And this is Korn, who described the first case of primary hyperaldo a long time back. And what he said was that primary hyperaldo should be very common. If you see any textbook, they say about 2 to 3%. At most, they give 5% as the cause of primary hyperaldosteronism as a secondary cause of hypertension. Why? Because we are still taught that look for primary hyperaldo if there's hypertension, hypokalemia, or if there's hypertension and an incidentally detected adrenal mass. But we have gone over that now. About 50 to 70% varies from series to series. people with primary hyperaldo will come to you with hypertension without hypokalemia. Of course, if you miss them for 10 years, I've seen so many cases after coming back to Kolkata where patients of primary hyperaldo have been missed for 10, 15 years. And some have come to the extent of getting admitted in a cardiology ward with cardiac dysrhythmia and getting a permanent pacemaker put in because potassium was 1.2. These are missed cases. So you should start picking them up early so that they do not end up in a cardiac ward getting a permanent pacemaker. So first of all, you have to suspect. When do you suspect? Hypertension with hypokalemia. Certainly, hypertension with hypokalemia on a diuretic. If somebody gets a diuretic, gets hypokalemia, you say, oh, the diuretic induced hypokalemia. But 10 patients getting diuretic, not everybody gets hypokalemia. So the people who are getting hypokalemia with a diuretic, you should think about primary hyperaldosteronism, especially if they're young. Resistant hypertension, when they are on 3 drugs, of which one has to be a diabetic, you are still having difficulty to control hypertension. Or if you're a diabetic, we did a study, part and parcel of being in a university. You have to keep doing studies to justify your position in a university. So I did the study of 100 patients with hypertension and of diabetics, 100 diabetics with hypertension who were on 3 drugs, blood pressure not controlled. And we did the whole test of, I'll tell you how to look for primary hyperaldo. And we found almost 13% at primary hyperaldosteronism. Prior to this study, there was only one study which showed about a prevalence of 14%. So the other causes, adrenal incidentaloma with hypertension. Always when I give a talk on adrenal incidentaloma, I say that if there's an incidentaloma, there's no hypertension, do not look for plasma renin and aldosterone. But hypertension, hypokalemia, adenoma plus hypertension or adenoma plus hypertension, hypokalemia, you have to exclude primary hyperaldosteronism. The others are familial ones, very rare, glucocorticoid remediable aldosteronism. I have not seen a single case so far, but those are the ones most discussed because those are the ones easy to diagnose. If you have a family history of early stroke, take the blood, do a genetic study, show the chimeric gene, and you've got the diagnosis, and you give them steroids. But I've not seen one. I've read about it, I think about it, but I've not seen one. So we should think about the top 4 in our day-to-day clinical practice. We are still missing primary hyperaldo, including me. Now, if you look at the prevalence, this is the table we summarized way back in 2010 when we did our study. In a diabetic, we found 30%. We all know Dr. Perez. He comes quite a number of times to India, especially to Pune. He had the earlier series of 2007. He found a prevalence of 14%. After these 2 papers, many other papers have come, not many, a few more have come, which have given a range of anywhere between 6 to 14%, including Japan, which says 15%. In diabetics who are uncontrolled on 3 antihypertensives or more. Now you think, how many you have in your clinic? How many of them do we investigate? We can't investigate because of the cost. So I'll come to a solution for that later on. In general population, Hiramatsu, who first gave the aldosterone-renin ratio idea in 1981, he said 2.6. But later on, if you take people with moderate hypertension, severe hypertension, or if you take people with resistant hypertension, then the prevalence becomes almost like 1 in 10 or 1 in 15. So you have to consider the possibility. Think about it. When you think about it, screening is very, very simple. It's basically with the plasma aldosterone concentration and plasma renin activity. Now the problem is lack of standardization. Now, this is a big problem in Calcutta when we practice. When I write PRA, PAC, I get all sorts of results. I get direct renin concentration. It might be reported in MU per liter, nanograms per liter. Some labs give me PRA in nanogram per ml. Some labs give me PRA in picomoles per liter. And PAC, sometimes I get in nanogram per DL, sometimes picomoles per liter. So I have this table stuck in front of on my table. This is impossible to remember all these cutoffs. What I grew up with was PAC and PRA. So this is what I remember, 20, 30, 40. But after coming to Kolkata, balls are coming either in swing, out swing, or bumpers. So to solve that, I bought the helmet, I bought all the guards. So I have this table in front of me now. No matter whichever unit they give it in, the cutoffs, the hair, you can take this picture, or you can just write the right endocrine society guidelines on primary hyperaldosteronism. This table is there. This table is very important in our local setup. And sometimes the direct renin concentration they do, or sometimes the plasma renin activity they do, may not be fully reliable. So one test may not be sufficient. You may have to do 2 or 3, which becomes very sensitive and difficult in our part of the world, because one PRA PAC costs of Australian colleagues, this might not be significant because you get it free for your patients. For us, very difficult. For something like 4,500 to 6,000 rupees, and to convince the patient to do when I was in Singapore, I used to do 3 PAC-PRAs before I used to think about doing further. But unless and until it's barn door 40 or barn door more than 1,000 per liter. But here I have to play with only one PAC-PRA ratio, and then things become a little bit difficult. So these are the difficulties in day-to-day life. This is impossible to remember. Drugs, so you just have this stuck in front of your, if you're doing primary hyperaldo work, have this stuck in your clinic. 3 drugs which you can give before investigating for PAC-PRA is verapamil, hydralazine, prazosin, doxazosin, terazosin. But if you are not able to control blood pressure, continue with your beta blocker, continue with your ACE-ARB, knowing fully well that you will have to interpret the ratio carefully. Only one drug which is not allowed is a mineralocorticoid receptor antagonist. You can't use a spironolactone or eplerenone and then do a ARR. Aldo will be sky high, you will be wrong. So you have to stop a mineralocorticoid receptor antagonist at least for 4 weeks, if not 6 weeks. Purists say 6 weeks, and practical people like me would say 4 weeks, and you do the ARR ratio. ARR cutoffs I've shown you. Once you meet the cutoff, you have to confirm the diagnosis. Now, confirming the diagnosis is basically intravenous salt load, oral salt load, captopril challenge, or fludrocortisone suppression test. Fludrocortisone is done only in one center in the world. It's a very difficult test to do. I have never even thought of doing a fludrocortisone suppression test. Captopril challenge test is no longer very good in respect to confirming or excluding primary hyperaldo. Oral salt load test is very much promoted by the Mayo Group, because they can't admit people for even 4 hours for the intravenous saline load. They can, but it's very expensive. So they ask the patient to take lots of salt for about 3 days, and then they do 24 hours urine aldosterone along with the 24 hours sodium excretion on day 3. Cumbersome test, and suppose your sodium excretion is less than 200, then you'll have to repeat the whole thing again. Becomes very difficult. So easiest is intravenous saline load. You get the patient in, give 500 ml per hour for 2 hours, 2 liters over 4 hours, and then do the aldo. The cutoff for the aldo is more than 10, you are 100% confirmed. 5 to 10 is again, see, endocrinology is always a gray zone area. You heard so much about thyroid nodule, about the gray zone area. Below 5, probably there is no primary hyperaldosteronism. So after you have suspected, after you have confirmed, you have to establish a differential diagnosis. Again, in our city, the only parameter that you have is a CT scan with 2 to 3 millimeter slices. We ask for 2 to 3 millimeter cuts of the adrenal gland. It will exclude an adrenocortical carcinoma as a cause of primary hyperaldo, which is very, very, very rare. So forget about that. They may miss very small adenomas, less than 5 millimeter or less than 1 centimeter. They are missed, but CT scan will not tell you that the adenoma that you're seeing is secreting the aldosterone. And MRI probably has no proven advantage over CT scan. So what people suggest is, if you see somebody above the age of 40 with an adrenal adenoma, or if you see bilateral nodules, you have to do venous sampling, which is available only in one center in our city. The other centers also tried, but I think the success rate which Mayo Clinic shows have been able to cannulate the right adrenal vein in about 95+% of the patients. That is not true. It is very variable from 2 to 6%. Mayo Clinic 98% time they are successful because they have a dedicated radiologist. Other centers struggle, including a couple of patients of mine who have gone to the south to get it done, and they come back with the indeterminate AVS results. So probably AVS becomes difficult, and we settle for medical therapy. So this is a very nice algorithm. Confirmatory testing, sodium load, I give IV, adrenal CT. If the age is less than 40 years of age, unilateral 1 centimeter nodule, if you go for surgery. Age is more than 40, or if you're seeing more than 2, you're seeing bilateral adenomas, you could send the patient for adrenal venous sampling, but most of us do not have it, and we generally go for mineralocorticoid receptor antagonist. So primary hyperaldosteronism is the most common identifiable, specifically treatable, potentially curable form of hypertension. With that, I will now come to the second common one, which is not common. The second one which needs to be excluded, that is a catecholamine secreting tumor. They are now called PPGLs. That is the group. When should we consider treating, testing for it? Suspect in patients with paroxysm and spells. I will not say I've seen so many FIOs, but I've seen quite a number of FIOs, and the FIOs coming with the characteristic Menard triad of headache, sweating, palpitation, I can count on my fingers. It exists in the textbooks, but I've not seen in real life. Maybe some of my colleagues from Australia may let me know whether they have seen this classic triad in about 1/3 of the patients with PPGL. Young hypertensive, now young you can define, but for this 32-year-old lady, I will consider she's got headache and palpitations. Hypertension, adrenal incidentuloma. Adrenal incidentuloma, even without hypertension, you have to exclude the PPGL before you go forward. So that 124 hours urine or plasma metanephrine has to be done. Paradoxical BP response to drugs or anesthetic. I've seen a couple of patients when I was abroad where unsuspected patient gets an anesthesia and suddenly has a very huge rise of blood pressure, and it turns out to be a PPGL. They can get secondary hyperaldosteronism because of intravascular volume depletion, and they can get hypertension with hypokalemia. Then the hereditary parts, I will leave it for this group. 3 steps you have to do. You have to screen and confirm. Then you have to localize, and genetic testing again. I'll again leave. There are 16 various mutations which have been described now. Most of them are not available to us, so we have to probably refer them. So I'll stick to step 1 and step 2. The cardinal rule of endocrinology: get the biochemistry right before you go for imaging, because adrenal incidentuloma is quite common. You do not get your biochemistry, some with hypertension, hypokalemia because of some other cause. You find an adenoma, you chop it off. You will be sorry because it was just a non-functioning adenoma, and the hypokalemia was for something else, and the hypertension was just essential hypertension. And after you have screened and confirmed, you have to localize. These tests are still available. I'm surprised. All the ones in red, please do not even read them. Please do not even do them. Just see the yellow highlighted ones. Measurement of fractionated metanephrines in urine, which would include both metanephrine and norepinephrine. Like a bit of an expensive test in our city, anywhere between 8 to 14,000 rupees is charged from different labs. And measurement of free metanephrines in plasma available in some centers, but be very careful because it depends very well on how you collected the sample. There are 3 methods by which you can measure the metanephrines or norepinephrines. So many of our assays in our part of the world are doing immunoassays. Now those results are a little bit difficult to swallow because sensitivity and specificity is not that great. Liquid chromatography with ECD, electrochemical detection, is used in some labs. The gold standard is liquid chromatography with tandem mass spectrometry, not available from all labs. You have to look for it, and they're a little bit more expensive. So if you want the best biochemistry, it's LCMS MS. If you are taking from the plasma, it should be collected in a fasting state. Patient should be off drugs which interfere. Again, you can't remember, have the list in your clinic. Patient has to be supine and rested for 20 to 30 minutes. Upper limits will vary depending on the methodology used. I do not do the plasma-free metanephrines. I rely mostly on urinary fractionated metanephrines. Why? Because it's easily available in most laboratories, not most, some laboratories, and urinary concentrations in nanomoles. It's a 1,000-fold high than what's in the plasma. So a little bit difficult to go wrong with the urinary one. You can go wrong. Where will you prefer the plasma one? If 24-hour urine collection is inconvenient for the patient, in children, 24 may be difficult. I do not deal with pediatric PPGL, so please don't ask me. And if there's renal failure, then it becomes very difficult because there's no 24-hour available. So you may have to do plasma-free metanephrines. Many a times we get with iffy reports, we don't know what to do when plasma metanephrine values are elevated 4 folds. You're sure. Between 2 to 4 folds, you're unsure. You don't know what to do. Urine more than 2 folds elevated, you have to start going for various forms of imaging. When urine is less than 2-fold and plasma is less than 4-fold, what do you do? Probably periodic follow-up versus proceeding with some part of the imaging so that you're not missing a barn door PPGL. These are gray areas, difficult areas. You have to refer to your specialist center. Even among specialist centers, we call each other. We take 2 or 3 of us give our opinion as to how far to go. Because there's no limit to localization. You can localize either with a CT, sensitivity specificity is there, or you can localize with MRI, or you can localize with an MIBG scan. Every PPGL should have an MIBG scan. I may be questioned for this statement, but we will see when it comes to question answer session, because it's highly specific, gives me the extent of the disease and gives me about metastases. Those of you who want to ask about PET-CT, PET-CT are very expensive, not easily available even to me in a tertiary care center. It's expense. If you want to do for PPGLs, fluorodopamine scan is the most specific, not available in our city. You can use the DOPA or the gallium scan also. Even a simple 18 FDG PET also can give you a pheochromocytoma, but if you're doing it, then do it with the dopamine or the DOPA scan. Now, Cushing syndrome, I will not touch because that is not part of the discussion here. Renal artery stenosis is a possibility in this 32-year-old lady. It's more common in females. This is not refractory hypertension. She's only on amlodipine. Blood pressure more than 20 years, unexplained renal dysfunction. None of that is there in our lady. But she is 32 and renal artery stenosis is common in this age group. There are 4 ways of detecting it. Ultrasound, Doppler, which we rely on, not very sensitive or specific. Another 3 minutes, Chairperson, sir. Or you can do a CT angio, or you can do an MR angio. MR angio is probably the best these days to look for renal artery stenosis. Now, once you find the stenosis, that doesn't tell you whether that is the cause for the high blood pressure. Previously, we used to do selective catheterization, measure differential renins and decide. But nowadays, majority of the times, young patients, fibromuscular dysplasia, people with either stent, or now we have very strong antihypertensives by which we can control, and you don't need any any kind of intervention there. So take home points: indiscriminate screening of all hypertensive patients for an underlying endocrine disorder is not indicated. Careful medical history and clinical examination are indispensable for a timely and correct diagnosis. Proper care must be given to optimize pre-test conditions for biochemical testing. Certain drugs have to be stopped, certain drugs have to be replaced, which is a very controversial area. Biochemical diagnosis must be completed before proceeding to imaging. This has been said 100 times and this has been ignored 100 times. Patients get all sorts of imaging and then come to us with bilateral adrenal adenomas, this, that, and then we are scratching our head what to do because biochemistry has not been done. And while doing biochemistry, we find that probably all biochemistry is normal. So we end up with an incidentaloma. Proper interpretation of lab tests is paramount. It's not easy. If we even ask all our endocrinologists who are sitting in the panel today, they will share their experiences with you. For PHA, the most useful initial screening test is aldosterone-renin ratio. For PPGL, it's 24 hours urine catecholamy, fractional metanephrids or plasma, free metanephrids. So this lady, 34 years old, exclude the secondary causes, get a creatinine done. Lady, think of renal artery stenosis, headache, palpitations, you have to exclude a PPGL. Gained 6 kg in weight. Please look clinically whether she's got Cushing syndrome or not. Most likely not. This is the weight gain of after marriage and after having the first child. Small form goiter. Is she hypothyroid? But hypothyroid will not cause such high systolic blood pressure. Is she hyperthyroid? Can cause systolic blood pressure, but then there will be other telltale signs. Now she's obese. So whether it's all obesity-related hypertension. The 3 things you have to exclude. There is a clinical examination to exclude Cushing's, and you have to exclude a primary hyperaldosteronism, mineralocorticoid hypertension, and a PPGL needs to be excluded because she's young. So these 3 tests need to be done. So these are the various things that you could find. The patient I was describing had a small adenoma, had clear-cut less than 32. Not this patient, the other one I was discussing had a nice aldosterone-secreting adenoma. This is a huge, big pheochromocytoma, classic Cushing's disease with a small, more than 6 millimeter pituitary adenoma. I don't need anything else. You can go and chop it. And a couple of patients with renal artery stenosis. With that, I will stop. Sorry, I've exceeded by 2.5 minutes. I was flustered in the beginning. Now I could not get my slides going. Thank you. Back to you, Demalu sir.
So thank you for an excellent talk, and summarizing a very difficult topic. Just 2 short questions that have come up till now is with regards to the fact that, do you advocate universal screening for primary hyperaldosteronism?
I do not, because primarily because of the cost reason. I would still do case selection. I will take somebody who is, I told you those indications. Somebody comes with incidentaloma, hypertension. Somebody has got unprovoked hypokalemia. Somebody's got provoked hypokalemia with a diuretic. A younger person, say below the age of 40 with very high blood pressure, then I would do a PAC-PRA ratio. I have to discuss with the patient in our city because it's expensive. I don't know what cost for you in RNT. For me, it comes to somewhere between 4,500 to 6,000 rupees. And then when I do it and it comes as negative, then the patients become a little bit sticky, asking, why did you do it? And if you do it and it comes positive, then you're talking about walking down the whole pathway, which is another about 10 to 30,000 rupees expense, maybe 40,000 rupees expense. So you have to discuss with your patient. We are not in a university setting like our Australian counterparts. We are in a day-to-day clinical practice. The patients pay out of pocket, because in the end, you see the treatment below 40 is surgery. Above 40, it's still giving mineralocorticoid receptor antagonist. So maybe the PAC-PRA, if you get the ratio high, you can A poor patient comes from a village, etc. I mean, see, this is my practice has changed. When I was in Singapore, I would never say this. I would say go to the end and do adrenal venous sampling and get the diagnosis. But in our setting, I would suggest that maybe you can consider mineralocorticoid receptor antagonist early on. Back to you.
Yes, and again, one question that is in patients who have CKD, how to evaluate for primary hyperaldosteronism? That has come up, especially in patients with CKD, because then there is
Can't hear you. Hello? Demola, I can't hear you.
Patients with CKD, sir, how to interpret the ARR?
Patients with CKD are difficult.
Yeah.
Patients with CKD with regards to PPGL, that's easier because you can get away with plasma catecholamines, plasma fractionated, not catecholamines, sorry, plasma fractionated metanephrines. With the renal failure, there are so many issues you see. If they are hypovolemic, if they are already on a mineralocorticoid receptor antagonist, they're already on 6 antihypertensives. So what is the point of getting an getting a primary hyperaldo diagnosed so late down the line when somebody is already on CKD, already on dialysis, already on end-stage renal failure? Doesn't matter. They're already on a mineralocorticoid receptor antagonist. It's very difficult to stop an MRA for 4 to 6 weeks in these patients because they are. I mean, all of us who see patients with the CKD on hypertension, they're on at least on 3 to 5 drugs to control their blood pressure. So it is a difficult, sticky scenario. If I get one, I don't know, I'll send to Professor Anirban Majumdar to take the drugs off and do the ARR ratio and move forward. If you want, this is one area where you may break the dictum of biochemistry first and imaging second. You may cheat and do an MRI and see if there is a juicy 3, 4, 5 centimeter or adenoma there. Then you have to be careful. Then you might be missing a PPGL. But with primary hyperaldo, I'm not too concerned in a patient with CKD. It doesn't matter. You just can add a little bit of mineralocorticoid receptor antagonist, get away with it. PPGL, if you miss, it's an issue. Back to you.
Thank you very much. Thank you, Jejida. If there are no further questions, for an excellent talk once more, every time I listen to your this hypertension, endocrine hypertension talks, it's always enriching, and I learn once more. Thank you. Thank you.